I'm funded by NIHR to do this work together with Matthew here on the first row. And the work is on neuraminidase inhibitors for influenza. This is what we've been doing. That's two drugs at the moment, Tamiflu, oseltamivir Roche, and Relenza, which is produced by GSK. It's just ran out of a patent. That's zanamivir. I'd like to thank Peter Doshi and his sister Molly McMahon for help with the presentation and with the graphics, and the organisers for allowing me to be here in this very historical city. This is what I'd like to talk to you about, but I will skip the bit, very much the bit about reporting bias, because Anwen's given us an exhaustive, authoritative review. But the question is, what is its impact on literature? And then I'd like to look at the case of neuraminidase inhibitors and what it tells us. And I'd like to talk to you about regulatory evidence reviews. So systematic reviews are made on, based on regulatory evidence. Are they feasible? How much do they cost? How are they feasible? And what does the future hold for the whole evidence-based movement, evidence-based medicine movement? Okay, so reporting bias, you've heard all about it. There are three references here to three studies, which I really, one narrative review and two studies, which I urge you to read. The first one is by Natalie McGarren and colleagues from IQWiG in Germany. That's the same stable as the work by Aiding on reboxetine. They are part Health Technology Assessment Park regulators, German, very thorough, very good work coming out of this group. The McGarren narrative review tells us about all the different types of reporting bias which you can find in the zoo, all the different beasts. And they range from publication bias, which is so well known, to things like swamping bias, which is less known. Swamping bias is mainly what regulators suffer from, because a regulator says, they don't say, I want everything. The manufacturer says, we will give you access to everything. You tell me what you want. Well, the regulator says, well, we'll look at 2 pivotal trials, okay? 2 out of 20. And the pharmaceutical company says, oh, but there's no problem. If you want to look at all 20 of them, we've got an ISO container full of paper. Just please let me know which slot in your parking lot you would like us to park the ISO container. Say, no, it's okay, thank you very much. We will just chug along with 2 clinical study reports, and perhaps if you're FDA, we'll rerun the analysis on the tapes you give us, a few checks, and then we'll rerun the SAS tapes that you give us. EMA have got a slightly different, but the point is that regulators don't do what systematic reviewers do. Regulators have a different task, so you cannot compare regulators with systematic reviewers. The other 2 papers that I would urge you to read are the ones by Selyoka et al. And Hemmans and Haynes, and both published very recently, and you will find the references in my slides at the foot with all my notes. Okay, so let's talk about reporting bias. Can you see him up there? Can you see him well? Now, that's our Admiral Beardless Altman on his flagship, HMS Consort. He's seeing, as he is navigating, all these different things, all these different balls, which are basically of 2 colors, green color, red color. Red color for a negative trial, negative between inverted commas, green trial for a positive trial, green color for a positive trial, but he can see them. Some are green, some are red, but Admiral Altman steers HMS Consort very skillfully through these balls. Alas, what he can't see, because sonar had not been invented in the times that Admiral Altman sailed the 7 seas, are the balls that are hidden under the surface. They're green, they're red, but they are invisible, both of them. So the question is he going to collide with them and sink his beloved flagship? There's an awful lot of balls out there, especially under the 7 Cs. Let's just take a look at the balls that we can see, regardless of their color. The tip has been published, and it's been published in the Journal of Very Important Results. This is a journal with an impact factor of 2.5 million, so you can trust it, and you know that everything that's published in there is absolutely true. What, however, has become quite clear in the last 3.5 years is that what you see published is not the reality, is not the trial. Below the waterline, and I remind you this is a visible ball, it's not an invisible ball, lie all these different elements. I have no time to explain in detail what all of these are, but if we all have a journal paper, then it means, and we use a journal paper, means that everything that we know should be in that journal paper, and that we rely on that journal paper 100%. And if we do that, we get it so badly wrong that you publish a nonsense Cochrane review on Lancet in 2006 of neuraminidase inhibitors, like we did, and you get it wrong. Wrong was misleading. The artist in this illustration could fit so many of these elements, but not all of these elements. So these are the main ones. But take it from, I'll give you a visual demonstration of exactly what's missing from view in a minute or so. Remember 2 things though. The proportion here is wrong. The tip is a lot smaller in proportion to the hidden mass of the ball. And the tip is published. At least the Admiral can see that there is something out there. He may not know how big it is below the waterline, but still he can see it. What he can't see are the submerged balls. Or a lot of balls, isn't it? So some of these elements you've heard of, the individual patient data. Some of the elements are never cited are the internal memoranda, the emails, the PowerPoint presentations, the business meetings, the investigators' brochures. These are vital, very important. Then you never hear talk about the case report forms, CRFs, which are basically the clinical notes for every participant in the trial. That's a goldmine. That is incidentally where the biggest danger lies, because hardly anybody sees these outside regulators. And then you've got the clinical study report, which is a huge pile of paper if printed out. Then you've got all these other elements. Look at this. Now, to have a bird's eye view of the complexity of these clinical study reports, you can read our descriptive review of 74 of these CSRs from 14 different drugs and biologicals. It's published on BMJ Open. You punch in Doshi, which is the first author, and out it comes. Now, I'd like to make the point about compression factors. We're going to concentrate now on the partly visible tip. This slide shows our estimates of compression factors for published trials. We define compression factors as the ratio of clinical study report, CSR, page length compared to the page length of the same trial published in a scientific journal. The objective of this metric is to convey the sense of how much information present in the CSR is condensed or compressed in a short journal publication. Consider the CSR's greater length and detail, level of detail. The size reflects this level of detail, as well as the presence of many of those elements that I showed as protocols and their amendments. Randomization lists, statistical analysis plans or SAPs, certificates of analysis, and extra data of subpopulation. I'll show you a certificate of analysis in a minute. We've demonstrated all these elements are vital for understanding the trial and the evolution of the trial and what happened to the trial and later. The process of compression is vital to understand the presence and the possible impact of reporting bias in literature, so in the published word. Why? Because when you compress, when you go to 8,000 pages, you throw away 8,000 pages and you compress them into one, then you are making decisions. You introduce value judgments, but these value judgments are unknown, they're inscrutable, they're hidden. Who's made them and why? We don't know. The impact of reporting bias is unknown. It's thought to be notable, as you've heard all these case reports, strings of case reports, all throughout the day you've heard them. But we don't really know what the impact is. We think that the impact is notable. Now let's move on to the case of neuraminidase inhibitors, in which 60% of randomized evidence for Tamiflu treatment trials is hidden. Was hidden 10 years ago, 15 years ago, and remains hidden to this day. There are major discrepancies between the clinical study reports and their publications. There's loads of ghost writers, then we've got ghost authors, we have guest presenters, we've got guest authors, we've got all sorts of things. We don't have a dead body like in the case in the case of Starflex, like Peter Wilmshurst told us about. And we don't even have a real dead guy writing letters and approving manuscripts. But we've got just about everything else in this concoction. These are the facts of the case, and may I remind you that Tamiflu is being widely promoted by public health agencies worldwide, and it's being financed by every one of you here today who's a taxpayer. You can read all this stuff and our correspondence on bmj.com/Tamiflu. Let's just look at a practical example, the case of WP16263. There are two versions of this Tamiflu trial. There's an 8,545 pager. That's the complete clinical study report, everything, including IPD. And then there's the published version. You were talking about publishing delay. It's interesting because this is what got published 9 years after the trial. And the authors are all industry, they're all Roche employees. Here it is, the published version of the trial, and I remind you that this trial is 16263, and it's called, in its published version, it's called Koski et al. 2010. Please, would you take notice of the placebo and the dose of the placebo, which is 12 capsules a day. Okay, 12 capsules of placebo a day in this trial to hide all the different comparisons, to conceal all the different comparisons. Right, here is the study. This is the complete clinical study reports pictured on Peter Dush's desk at Johns Hopkins in Baltimore. But it's not the actual printout, the CSRs, don't worry, for the greens amongst you. They're just reams of paper made up to look like 8,545 pages. This is the portion of individual patient data, and the left-hand side is the IMRAD, if you like, discussion, if the IMRAD portion of the CSR. Now, you'd be quite sane if you were daunted by this volume of stuff. Daunted and you wouldn't eyeball it or read it. You would be quite sane. But what you would also be is missing pages 422 to 423. And you can see them down there, okay? What do they hold? They hold a certificate of analysis. Clinical study report contain these. It's an authenticated document certifying the constituents, quality, aspect, purity of a product. In this example, we have a record of the appearance of Tamiflu and placebo capsules. The active principle on the left of the screen and the placebo capsule on the right. The Tamiflu capsule had a grey opaque body, but a light yellow cap, while the placebo capsule had an ivory coloured cap and an opaque body. Now, these details are neither present in the publication nor in the core of the clinical study report, the main body of the clinical study report. And the placebo is called matching. Well, even I know, I'm a bit colorblind, but even I know that yellow is not ivory white. Now, is this important? Well, maybe we don't know for sure, but it's certainly something that you would miss in a 10-page publication. You'd also miss the fact that in the placebo, there is a substance called dihydrochloric acid, which is a substance which we all produce, as you know, in bile salts, and if given in large enough doses, gives you the squits. And if it gives you the squits in the placebo arm, then you might not notice the squits in the active arm. Maybe yes, maybe not. I can't say one way or the other, or I'll get sued. Notice what it says here, okay? Matching placebo BID for 5 days. It ain't matching. So, given what we found, could we trust the published word? Well, as you saw, it's all over balls, really. And my group, therefore, sought refuge in regulatory information. Thanks to Peter Goethe and the EU Ombudsman, we have access to regulatory information from the European Medicines Agency as we speak. So we have now the fantastic option of doing that. It's not the whole set, but the majority of the CSRs, the important CSRs, will be there. Now, we produced this thing on the 18th of January 2012, which is the first example of a Cochrane review based entirely on regulatory information. No publication, no published evidence. No published evidence. No published evidence. But going back to my friend Admiral Altman, is this forensic exhaustive approach, as he would say, feasible? Does it change anything? Well, the table here that you see describes the output of data release from the EMA in the last 2 years, from November 2010 to November 2012. This was published as a letter in the last issue of Archives of Internal Medicine before it changed its name. It transmogrified into JAMA Internal Medicine. Right. As you can see, they have coughed up 1.6 million pages of sundry regulatory documents in the last 2 years. So the approach is feasible. This approach is feasible for now. Now, by the way, who are the winners in all this? Who got the most number of pages? Can you see it? Industry. Industry. They probably got a lot more than that because under media, they also appear probably under media, legal, perhaps institutional, certainly academic. So, journal articles, especially of pharmaceuticals, I think are likely to be spun adverts. And it doesn't really matter whether they are green or red. So if you really want to get a grips with things, there is only one way, a thorough, systematic, and independent way, as those lunatics who read that pile on Peter Dosh's desk at Johns Hopkins. But, and here's the snag, it's manpower heavy. And we got to learn a new whole set of skills and construct a new set of instruments to do this work. Now, my last slide, I try to look forward. Will there be a paradigm change for EBM? Certainly in where we find the evidence and where we include it. Well, there are pros and cons which need to be debated openly and in an adult fashion. I personally think that old methods of systematic reviews are defunct, or would I say search methods of systematic reviews. There is mounting empirical evidence, and these were the articles I was referring to, that a quick search will give you the same results as an incredibly detailed search of published evidence, because the core of the evidence on trials in biological is commercial. And so if you look at 2 trials, if you look at 10, the message is still the same. In some cases, like in the review by Salioka et al., they found that even the odds ratios did not change if they did a quick search or a thorough search. Now, of course, this research needs to be replicated. We need to understand better what the limits are. But if the search is carried out only on regulatory material, that only regulatory material is included, I will promise you that the results will change, your conclusions will change. This is a promise. You can trust me, I'm a doctor. If the corpus of published material, especially the pharmaceutical-sponsored trials, is nothing more than marketing material, looking at 2 trials or 10 trials ain't going to change much. Thank you for listening to me, and thank you very much for having me.